Right, so again, ladies and gentlemen, a warm welcome to the webinar. Before we go to the other lectures, I'll give you just a brief summary of what IRE actually is. An IRE is reversible electroporation. It's short electrical pulses between a minimum of 2 needles. The important thing is that all the cells within this volume are treated, and the tissue architecture stays intact, and I'll show you a couple of slides of that just in a minute. And we have no heat sink effect because the treatment effect is not heat but the electrical pulses. And what happens is that if you have a cell in an electrical field of the right current, you get little pores in the cell membrane, and if the current is correct, then when you switch off the electricity, the pores will remain in the cells. The cell then thinks it's old and will die. So this is literally inducing apoptosis. You can see here on the slide where the ablation area is, but you still have the normal architecture of the tissue, which means that the collagen structures of blood vessels will remain intact. The advantages here, if you look at this image, if this, you see where we placed 3 needles and the ablation zone goes around there. If this had been a portal vein, we would have had a bile duct going next to it, and most of our surgeon friends will not be very happy if we ablate a bile duct centrally in the liver. Even when it's a hepatic vein, we still have a problem with the heat sink effect. If a tumor cell has invaded the vessel wall, that will be cooled if we do a microwave or an RFA ablation. Another advantage is that as we do not have a coagulated lump of tissue in the liver, the ablation zone will disappear fairly fast, especially compared to a microwave or an RFA ablation, because as I said, there's no coagulated lump of tissue, and you have perfusion through the area that's been ablated. So if you have patients with multiple ablations where it might at the end be quite difficult to see what is ablated, what is a new tumor and what is an ablation, this helps. Just showing you, I know the subject today is pancreas, but this is just showing you the difference. We have a patient with metastases from a colorectal cancer. You have one metastasis down there on the IVC. You have another metastasis up here, just under the only remaining portal vein. As you can see, the patient has had a right hemiapatectomy. And we placed needles around, 3 needles around this lesion, 1 on either side of the portal vein. And this is what it looks like 24 hours later, which is a longitudinal contrast-enhanced ultrasound image where you have the portal vein in the middle there, and you can see vessels, normal vessels, being intact. And if you compare this to what you see up here, which is a microwave ablation, where in the IRE ablation you have vessels intact, whereas in the microwave ablation you have no vessels whatsoever. Big question, of course, when we start doing things that we haven't done before is this something that's safe to do? Because we can't really do serious research studies if we haven't proven that it's safe. One of the things is, do we actually give any heat or do we not give any heat? This is a slide that I've borrowed from Hester Schäfer from Amsterdam, showing that we have a little bit of heat actually just by the needle, but not to a significant degree, as far as we know now. This is a summary of the complications, trying to answer the question, is this safe or not? This is a summary of the first 50 pancreatic ablations that we did in Uppsala. And you will notice that we have, if I'm correctly informed by my surgeon friends, this is the Dindoclavian scale, and the divider is here between 3A and 3B, because complications for 3B will need to be sorted out with some sort of surgical intervention. And out of 50, we have 3 that needed that type of intervention. One patient actually died because of respiratory failure when we tried to relieve a bile duct obstruction the day after the ablation. So it was not actually at the time of ablation. And then we had one bile duct perforation and one thrombosis that we needed to do surgery on. The rest of them, as you will see, are fairly small things that we've dealt with percutaneous drainages. Pain and infection dealt with paracetamol mainly and antibiotics. Things when you start doing IRE, there are a few things that you need to discuss. One of them is how do you actually guide the needles to the position where they want to be. You can obviously use ultrasound, you can use CT, and you'll have both of these explained a little bit later on tonight. You can do it under laparoscopic guidance, or you can do it intraoperatively. One discussion point is if we have metallic bits in the patient, like stents and clips, when to treat, and you'll have some of the clinical oncologists later on to discuss that. One thing to remember when you compare results is that if you compare results from an open approach to a percutaneous approach, you can't really do that, because the percutaneous approach will have patients with early metastasis that it's discovered if you do it openly. So we will include patients that have a greater chance of early recurrence in those groups. There is a learning curve when you start doing IRE, but there is a learning curve with everything. Another thing, so we get the expectations right, is that it's important to remember that we do not repair what the tumor has actually damaged. So if you have a bile duct obstruction and you do an IRE of the tumor, that will not relieve the bile duct obstruction. It's just, so don't expect that things will go back to normal when you've treated the tumor. The tumor is hopefully gone, but the damage done to the distal bile duct is still, or pancreatic duct is still there. We place between 2 and 6 needles. The machine will take up to 6 needles. You have the ablation zone will have the shape of a cylinder, a fairly low cylinder, and the height of the cylinder is determined by how much of an active needle that you have. But most people work with up to 2 centimeters. Usually 1 to 1.5 centimeters outside the liver, and maybe 2.5 centimeters in the liver. If you need the cylinder to be higher, you need to pull back the needles and treat again. We need to do it under general anesthesia, because we put up to 3,000 volts into these patients, and they need to be muscle relaxed to a degree that is not usual, because otherwise the patient will twitch on the table. You can remember that placing needles on both sides of a vessel seems to be not a problem, because we've done it on several occasions, and it's vital when you treat near the head of the pancreas. When it comes to the method you should use, I would like to introduce Lexi up here in the right corner. Lexi is a black Labrador, and this is the kennels where we picked her up, and this is where I live in southern Sweden. If you do Google Maps how to get to the kennels, you come up with 3 different ways. So say one is ultrasound, one is CT, and one is intraoperative, but all the roads lead to the kennels. The important thing is that we place the needles in a correct position around the tumor, the way we want them. Okay, that was a summary of what the technique is and the basis of IRE. So now you know what you will refer to when you hear the following presentations. Thank you.